So what I want to do is break these down and kind of give you a little bit of that question and answer format, and so that you can be prepared for some of these on the test. So let's first talk about the watery diarrheas, the watery acute diarrheas, and we'll start with some viruses. So what do you think the virus would be if you had gastroenteritis in a young child? This is associated with daycares, and the vaccine is associated with intussusception. So this would be leaning you toward rotavirus. On the other hand, what if you had gastroenteritis and it could be anybody, any age? It's most common in the winter months, and they love this association with cruise ships. So that would be norovirus. Moving on to some bacteria. If you saw watery diarrhea after travel, they love it. Travel to Mexico specifically. It has the nickname Montezuma's Revenge, and there's two enterotoxins that you need to recognize. This is ETEC, enterotoxigenic E. coli. And my next question while we're here is whether you know the two enterotoxins that are associated with ETEC. So those two are the heat-labile toxin, also known as LT, and the heat-stable toxin, also known as ST. And so how does the heat-labile toxin work? So what is its mechanism of action? So its mechanism of action actually is that it activates adenylate cyclase. And what that'll do, that activation of adenylate cyclase, will end up promoting the secretion of chloride and water into your GI lumen. On the other hand, the heat-stable toxin mechanism of action is a little different. This will activate guanylate cyclase. And guanylate cyclase, if you activate this, it'll actually decrease your ability to reabsorb sodium chloride and water. And so it'll be stuck in the GI lumen. And in both of these cases, you'll get that diarrhea for different reasons, though. And so a couple mnemonics that you might have been familiar with regarding how to tell the difference between LT and ST. Sketchy uses the mnemonic. They show that picture and they show El Agua de San Gabriel, where they look at the L and the A go together. So that'll tell you that LT activates adenylate cyclase, and the heat stable toxin, which is ST, will activate guanylate cyclase. My favorite mnemonic for this, I think I saw it in first aid, I could be wrong though, is labile like the air, stable like the ground. And that always helps me remember that the LT is associated with adenylate cyclase activation, whereas the stable toxin, the ST, is associated with guanylate cyclase, the G. So whatever works for you to remember this, but this is definitely tested. Okay, so let's move on. So what if you have a curved rod? So what is this? So you have a curved rod. It is responsible for significant rice water stools after travel to Asia. It's treated with oral rehydration therapy. So this is cholera, so by the bacteria Vibrio cholerae. And so the cholera toxin, what is its mechanism of action? They do test this quite a bit too. So this will activate adenylate cyclase. And what that does is it'll secrete fluoride and water into the GI lumen. And hopefully this should look very similar. This is the exact same mechanism of action that we just saw in the heat-labile toxin of ETEC. So if you see, I've highlighted it here. And if we go back to the LT, the heat-labile toxin, exact same mechanism. So sometimes they'll give you an example where you know it's cholera, and then they'll ask you, they'll say, this toxin has the same mechanism of action as the toxin of which other pathogen, and then they'll list off a bunch. And in this case, you'd have to pick ETEC, or you'd have to pick the toxin. They might ask you what's the toxin, and you'd have to pick LT, heat-labile toxin. So what if you had nausea, vomiting, and diarrhea after consuming unrefrigerated meats, dairy, or baked goods? Oftentimes in the question stem, multiple people will be affected because it'll be at something like a picnic or a fundraiser. So this is Staphylococcus aureus food poisoning. How about if you saw a question that had watery diarrhea associated with reheated rice? And there's two enterotoxins associated with this bacteria. So that reheated rice should be a buzzword for Bacillus cereus food poisoning. And the two enterotoxins that are associated with B. cereus are the diarrheal enterotoxin and the emetic enterotoxin. So let's talk about some more bacteria. What if you see somebody who has watery diarrhea that starts after a prolonged hospitalization? I hope you're thinking about Clostridium difficile, so C. diff infection, and a few medications that are associated with C. diff. This can go a lot of different ways, but clindamycin is heavily tested. You can get cephalosporins, not as heavily tested, but in practice, you'll see more C. diff because of cephalosporins compared to clindamycin, mostly because cephalosporins are just used so much more as well. You can see it in ampicillin, fluoroquinolones. You can also see it in PPIs. So what I want you to remember from this slide, definitely they love to test this clindamycin, but just remember that pretty much any antibiotic is a possible contributor. And then for PPIs, we did talk about this in the stomach lecture when I talk about PPI pharmacology. I just want to remind you that that decreased acid in the gastric lumen will allow some of the bacteria to proliferate. So you're at risk of several different either bacterial overgrowths or you're at risk of different infections because of that. That's a little bit lower yield. I just wanted to have a little bit of a callback though to something we talked about in the stomach lecture. So now let's talk about what watery diarrheas might form due to certain parasites. So what if you saw somebody with foul-smelling diarrhea and steatorrhea, which just means fat in the stool, and it's associated with outdoor water consumption and like a camper or a hiker. So this is talking about Giardia lamblia. And so how many trophozoites? I mean, how many, sorry about that. The trophozoites of Giardia, how many pairs of flagella do they have and how many nuclei? So they usually have 4 pairs of flagella and 2 nuclei. And if we look at a picture, those 2 nuclei kind of give you this classic, almost looks like a face looking at you. And they do like to show the histology so that you know that this specifically is the trophozoite of each Giardia. What if you saw somebody who has HIV and AIDS and they end up presenting with profuse watery diarrhea and they haven't been taking their antiretroviral medications? This parasite is associated with contaminated food or water sources. So that's going to be something called cryptosporidium. And you can diagnose this. There's a few different ways, but a way they like to test it, they want you to know that this specifically can be diagnosed on stool. If you do a stool O&P, it'll stain acid fast positive. And you can treat it. The one you should probably pick on a test is nitazoxanide. It's an FDA-approved medication for cryptosporidiosis. Spiramycin might be mentioned, but if both of these are provided, I would definitely pick nitazoxanide. So that was just a quick framework about all the different causes of acute watery or non-inflammatory diarrhea that might be presented on a clinical vignette. I might have missed some, so just keep in mind on that. Like when I go through all these Q&As, whether it's acute diarrhea, chronic diarrhea, GI bleeding, I try to be comprehensive with it, but if it may or may not be exhaustive. What I want to do now, though, is talk about all of the causes of acute inflammatory diarrhea that you're likely to see on test day. So what's the most common cause of infectious bloody diarrhea in the US? This bacteria is a curved rod. It's associated with undercooked poultry and meat, and it may cause Guillain-Barré syndrome. This is Campylobacter jejuni. How about what if you see somebody who has bloody diarrhea after consuming undercooked beef? It has a classic O157H7 variant. It's associated with hemolytic uremic syndrome. It has a Shiga-like toxin, and it does not ferment sorbitol. This is enterohemorrhagic E. coli, or EHEC. What if you had watery or sometimes bloody diarrhea in children? It's in the same class as EHEC and ETEC. This is less tested, but this is your enteroinvasive E. coli, so EIEC. And the last one I have on this slide, bloody diarrhea in an infant or child, strong associations with daycare, pork, and unpasteurized milk, and it can cause something called pseudoappendicitis. This is Yersinia enterolytica infection. How about a bloody diarrhea or fever after recent travel to either India? India is very heavily tested on this disease, but it could also be somebody traveling to China or Africa. This bacteria invades your pyre patches, and you need a very large inoculum. So you need a lot of this bacteria to enter your GI tract to become infected. This is a Salmonella typhi infection. What's the macular rash that it's seen in about 30% of individuals with a Salmonella typhi infection? So those are called rose spots. So they might give you that as a symptom as well in order to increase your likelihood of picking Salmonella typhi. And if you have chronic Salmonella typhi, what are you at increased risk for regarding cancer? So that's actually gallbladder carcinoma. And when we talk in our hepatobiliary unit later on, you'll notice that one of the risk factors you'll find is this chronic Salmonella typhi infection. So what if you have somebody who, it's the same family that we've been talking about here, and they present with gastroenteritis and non-bloody diarrhea. This is associated with undercooked poultry and pet reptiles. So this is Salmonella enteritidis. And keep in mind, this is not technically an acute inflammatory. This one right here, it's a non-bloody. So this is actually a watery diarrhea. I just wanted to put it in here just so you can see the two differences between the different subtypes of Salmonella that they like to test. And again, this is just a question more broadly related to Salmonella. So Salmonella osteomyelitis, they want you to know what if you see somebody with Salmonella osteomyelitis, what comorbid condition may they have? And they like the association. If somebody has sickle cell disease, they're at increased risk of Salmonella osteomyelitis. Now, I want you to understand this distinction as well. So people with sickle cell disease can get Salmonella. So if you see somebody with Salmonella osteomyelitis, you should pick sickle cell disease. With that said, if somebody has sickle cell disease and they develop osteomyelitis or they develop a septic joint, what's the most common contributor? A lot of people here think the opposite is true, and so they want to pick Salmonella. It's actually not. Staph aureus is your most common cause of osteomyelitis in pretty much any disease condition. That doesn't mean you can't get Salmonella from if you have sickle cell disease. It's definitely a risk factor, but still, your most common cause of osteomyelitis in a patient with sickle cell disease is still going to be Staph aureus. What if you find somebody who has bloody diarrhea after travel or after some sort of contaminated food or water exposure? This, similar to Salmonella, will invade your pyre patches, so those M cells. But in contrast, you're going to require a very low inoculum. So this thing is very infectious and it produces an eponymous toxin. So the toxin is the same name as the disease itself. So this is your Shigella. This is Shigellosis or from Shigella sonnei. And so it has a Shiga toxin. And so what's Shiga toxin's mechanism of action? So what it does is it'll invade the 60S ribosome, and if you invade that, you're going to inhibit protein synthesis. And I wanted to mention, again, similar to how we saw that with cholera and ETEC, we also saw this with in my oral cavity lecture, I talk about diphtheria and how diphtheria's toxin has the same mechanism as Pseudomonas exotoxin A. They really like you to know if something has a similar mechanism of action. So in the case of Shiga toxin, what's the other toxin that has the exact same mechanism of action? It's going to be the Shiga-like toxin, and that's part of EHEC, enterohemorrhagic E. coli. So here's EHEC. We talked about this earlier. You can see this Shiga-like toxin. And so this does the same thing as the Shiga toxin that we're talking about now, namely inhibiting that 60S ribosome, which will inhibit protein synthesis. So yeah, just again, diphtheria and Pseudomonas exotoxin A, remember those two. Remember cholera, and remember ETEX, heat-labile toxin with that adenylate cyclase activation. And then finally, remember this one, the Shiga toxin of Shigella, as similar to the Shiga-like toxin of EHEC. Okay, so what if you had a parasite now that's causing bloody diarrhea, flask-shaped ulcers, and this parasite may form abscesses in your liver, lung, and brain. So this is Entamoeba histolytica, and I talked about this in the liver section. So if you don't know that yet, that's okay. I'll just show you kind of how it works. So most of the time, 90% of the time actually, Entamoeba will become non-invasive. And so how that works is that you have an Entamoeba cyst, it'll mature into a trophozoite and attach to your intestinal wall. And then basically this won't invade, it'll just produce a bunch of cysts that can reinfect other people. Now, this is the most common subtype. This happens more often if you do get infected, but they're not going to test this because this is not unique. What's unique about Entamoeba is that about 10% of the time you can get invasive disease. And so what happens there is that cyst will mature into a trophozoite, and that'll attach to the intestine and it'll actually invade. And so as it invades the intestine, it'll form these classic flask-shaped ulcers. And as it invades, you'll also get that bloody diarrhea that I was just talking about because of that intestinal mucosa damage. So these trophozoites will enter your bloodstream and they can consume red blood cells. They also may develop abscesses in your liver, lungs, and brain. So just keep that one in mind. And especially they'll always mention this bloody diarrhea, and that's because it's actually invading your intestine. On microscopy, I kind of gave this away. It's going to show you trophozoites with engulfed red blood cells. So here's a picture that I mentioned in the liver section. You have these red blood cells inside of the trophozoite. They like you to know the intraluminal agent that you need to kill the cysts of Entamoeba. And so I'll give you those right there, the idonoquinol and paromomycin. And you can use metronidazole to treat a systemic Entamoeba infection. And I'm just going over this just to give us at least one opportunity, and this will be from the liver lecture, excuse me. I wanted to talk about metronidazole at least once in this lecture, since there's a lot of these bugs that might respond to it. And so the good mnemonic that I've seen, I can't remember where this was from, but I do like this one. It's get gap on the metro. So the metro will remind you of metronidazole, and this get gap, if you've ever seen, like, I think this is mostly in the underground in London, where you have this mind the gap at their metro stations. This will remind us of this get gap mnemonic. So the G stands for Giardia. The E stands for the Entamoeba histolytica, which we're talking about now. You can also use metronidazole for Trichomonas vaginalis and Gardnerella vaginalis. Anaerobic infections tend to respond to metronidazole. And then H. pylori quadruple therapy also uses metronidazole. And here's from our stomach lecture. I just wanted to reiterate that metronidazole is used in that H. pylori quadruple therapy, excuse me. Thanks for watching. I hope you enjoyed the video. Please like, comment, and subscribe for more content.